The pill that helps you sleep tonight may turn the short walk to your bathroom at 2 in the morning into the most dangerous 10 seconds of your day. And a medicine that has controlled your blood pressure for years can begin affecting you differently after 65, especially after a dose change, an illness, or a hot day when you have not had enough fluids. That sounds alarming. But understanding the risk gives you a chance to prevent it. Picture this. You wake up in the dark, your mouth is dry, you swing your feet to the floor and stand quickly because you need the bathroom. For 1 second, the room seems to shift. Your legs feel a little delayed, almost as if your brain gave the command but your body received it half a beat late. You reach for the dresser. There is nothing there. Then everything changes in a single step. Most people would blame the rug, weak legs, poor balance, or simply getting older. But sometimes the hidden piece of the puzzle is sitting inside the medicine cabinet. Not because the medication is bad, and not because it was prescribed incorrectly, but because aging can change how the body absorbs, distributes, and clears medicines. Add 2 or 3 drugs with similar side effects, and mild dizziness can become a serious fall risk. According to the Centers for Disease Control and Prevention, more than 14 million Americans aged 65 and older, about 1 in 4, report a fall each year. Falls are the leading cause of injury in this age group. Yet here is the part many families never hear. Falls are not an unavoidable price of aging. Many risk factors can be found and changed, and a careful medication review is one of the most practical places to start. In this video, we will examine 7 common medication groups that can increase fall risk in some older adults. Number 3 is sold without a prescription and may be hiding inside a product labeled PM. Number 4 includes medicines millions of people need for their heart and blood pressure. And near the end, I will give you 5 exact questions to take to your doctor or pharmacist so you can protect your independence without making dangerous changes on your own. This video is for education only. It is not a diagnosis and it is not a reason to stop any prescription. Some of these medicines can cause serious withdrawal or allow a medical condition to become uncontrolled if they are stopped suddenly. The right goal is not fear. The right goal is a personalized review with a licensed healthcare professional. Before we continue, tell me in the comments, have you or someone you love felt dizzy after standing up or had a fall in the past year? You do not need to name your medications. Your answer may help another family realize they should start this conversation too. And subscribe for practical, evidence-based guidance for healthier aging. Before the first medication, it helps to understand why a pill can feel different at 70 than it did at 50. With age, the kidneys and liver may clear certain drugs more slowly. Changes in body water, body fat, and muscle can alter where a medicine travels and how long it remains active. The brain may also become more sensitive to medicines that cause sedation. None of this happens at exactly the same age or speed for everyone, which is why the number on your birthday is only a signal to review, not a diagnosis. There is also something clinicians call polypharmacy, which usually means taking several medicines at the same time. More medicines do not automatically mean poor care. A person with diabetes, high blood pressure, heart disease, arthritis, and anxiety may have valid reasons for every prescription. But the more products on the list, the more opportunities there are for overlapping effects, interactions, and confusion about timing. Risk is also dynamic. It can rise after a hospital discharge when a new drug is added, after a dose increase during an infection, or when dehydration temporarily reduces blood pressure and kidney function. That means a medicine can be tolerated for years and still deserve review after a new fall. The key question is not, is this a bad drug? The better question is this still the right medicine at the right dose, in the right combination for me today? The first group is benzodiazepines. Common names include alprazolam, known as Xanax, lorazepam or Ativan, diazepam or Valium, and clonazepam or Klonopin. These medicines may be prescribed for anxiety, panic attacks, muscle spasms, seizures, or short-term sleep problems. For the right patient and the right reason, they can be useful, but they also slow activity in the central nervous system. That calming effect can come with drowsiness, dizziness, muscle weakness, slower reactions, and impaired coordination. After 65, the effect may last longer than expected. A person can take a pill at bedtime, sleep for several hours, and still be less steady during a midnight bathroom trip or early the next morning. Importantly, the American Geriatric Society notes that shorter-acting benzodiazepines are not automatically safer than longer-acting ones when it comes to falls. The biggest danger may be the combination. A benzodiazepine plus an opioid pain medicine, alcohol, or another sedating drug can amplify impairment. The FDA also warns that benzodiazepines can cause physical dependence and that stopping abruptly or reducing too quickly can trigger severe withdrawal, including seizures. So if this medicine is on your list, do not throw it away tonight. Ask whether the reason for taking it still applies, whether the dose remains appropriate, and whether a gradual supervised plan or a safer alternative should be considered. The second group is prescription sleep medicines, often called Z drugs. Zolpidem, sold as Ambien, Esopiclone, sold as Lunesta, and Zaleplon, sold as Sonata. People sometimes assume these are gentle because they are not traditional benzodiazepines, but they still act on the brain and they can affect alertness, coordination, and judgment. The FDA has specifically warned that Zolpidem can impair activities requiring full alertness the next morning, even when a person feels awake. In older adults, blood levels can be higher, which is one reason lower doses are generally recommended. Now connect that information to a real home, dim lighting, bifocals, a loose slipper, and a person who has just awakened suddenly. Each factor may seem small, but together they narrow the margin for error. If a sleep medicine was started years ago, ask whether it is still helping in a meaningful way. Also ask whether untreated pain, sleep apnea, restless legs, nighttime urination, caffeine, or an irregular sleep schedule is driving the insomnia. Simply adding another sedative may cover the symptom while leaving the cause untouched. Again, never stop a long-used sleep medicine suddenly without professional guidance. Number 3, surprises many people because no prescription is required. Diphenhydramine, commonly known as Benadryl, is used for allergies and is also included in some nighttime pain and sleep products. Doxylamine appears in other over-the-counter sleep aids. The package may look familiar and harmless, but familiar does not mean risk-free after 65. These older antihistamines have anticholinergic effects. In plain English, they can cause sedation, blurred vision, dry mouth, constipation, confusion, and problems with coordination. A person may take a PM product for back pain without realizing that the second ingredient is a sedating antihistamine. Then they may also take a separate allergy pill containing the same or a similar ingredient. That is why reading the active ingredients matters more than reading the large brand name on the front. This is a perfect medication review question for a pharmacist. What is a safer way to treat my allergy, pain, or sleep problem given my age and my other medicines? Bring every over-the-counter bottle, including cold remedies and products marked nighttime or PM. Do not assume your prescriber knows about something you bought at a grocery store months ago. Number 4 requires balance and honesty. Blood pressure medicines save lives. Uncontrolled hypertension can lead to stroke, heart attack, kidney damage, and other serious problems. This section is not saying that everyone over 65 should avoid them. It is saying that a blood pressure plan should be reviewed when a person develops dizziness, faintness, weakness, or a fall. Medicines such as lisinopril, losartan, amlodipine, beta blockers, and others lower blood pressure in different ways. Diuretics such as hydrochlorothiazide or furosemide help the body remove salt and water. Problems may appear when the pressure drops too low for that individual, when several medicines have overlapping effects, or when dehydration, vomiting, diarrhea, fever, poor appetite, or hot weather changes the equation. Some people experience orthostatic hypertension, a drop in blood pressure after standing. The clue is a wave of lightheadedness, dimmed vision, or weakness within seconds of rising from a chair or bed. Diuretics can add another practical risk. They may increase the need to urinate, causing someone to hurry to the bathroom, especially at night. If this sounds familiar, keep a short record of the time, symptoms, recent doses, fluid intake, and blood pressure if your clinician has advised home monitoring. Ask your healthcare professional to measure blood pressure while lying or sitting and again after standing. Do not skip doses to run your own experiment. A clinician may need to adjust the dose, timing, combination, or monitoring plan while still protecting your heart. If you take lisinopril, losartan, or amlodipine, I have another detailed video explaining the numbers and warning signs worth monitoring after 60. I will place it on the end screen and in the description. Finish this list first because the next 3 medication groups are often combined with the ones we have already discussed. Number 5 is antidepressants. This includes medicines such as sertraline, escitalopram, and fluoxetine, medicines such as duloxetine and venlafaxine, and older tricyclic antidepressants such as amitriptyline. These drugs treat serious conditions, and some are also prescribed for nerve pain, migraines, or sleep. Untreated depression itself can reduce concentration, activity, strength, and self-care, so the answer is never a careless command to stop treatment. The evidence is not identical for every antidepressant, but geriatric guidance recommends caution in people with a history of falls or fractures. Depending on the drug and the person, possible contributors include sleepiness, dizziness, changes in blood pressure, slowed reactions, or low sodium. Risk can be more noticeable during the first weeks after a dose increase or when another brain-acting medicine is added. Here is the useful question. Since starting this medicine or changing the dose, have I become less steady, more sleepy, or more lightheaded? A family member may notice small changes first, holding the wall in the hallway, hesitating on steps, or falling asleep in a chair more often. Report the pattern, not just the word dizziness. Details help the prescriber separate a medication effect from anemia, infection, an inner ear problem, heart rhythm issue, or another cause that needs attention. Number 6 is opioid pain medicine, including hydrocodone, oxycodone, codeine, and tramadol. After surgery or during severe pain, an opioid may be appropriate. But opioids can cause sleepiness, dizziness, confusion, and slower reaction time. The CDC advises extra caution and monitoring in adults 65 and older, including assessment of fall risk and cognitive effects. The first few days, a higher dose or a new combination can be especially important. Imagine someone recovering from knee surgery. Their walking is already altered. They may be using a cane, waking at night, and taking a new pain medicine. If they also continue an anxiety pill or sleep aid, the combined sedation can be much stronger than either medicine alone. Alcohol can add another layer of impairment. Ask how long the opioid is expected to be needed, what the lowest effective dose is, and whether non-opioid or non-drug approaches can safely reduce the amount required. If an opioid and a benzodiazepine appear on the same medication list, that deserves a direct conversation with the prescriber and pharmacist. Do not change either one abruptly on your own. Seek urgent medical help for extreme sleepiness, inability to awaken, or slow or difficult breathing. The seventh group includes medicines for nerve pain and muscle spasms. Gabapentin and pregabalin may be used for seizures or burning, shooting nerve pain. Muscle relaxants include drugs such as cyclobenzaprine and methocarbamol. These are different medication classes, but they share an important concern. Sedation, dizziness, and impaired coordination can make a vulnerable person less steady. Kidney function matters for some of these medicines because the body may clear them more slowly when kidney function declines. A dose that once felt comfortable may later cause more daytime sleepiness or mental fog. Muscle relaxants may also have anticholinergic effects or cause weakness. The danger rises when one of these drugs is combined with an opioid, sleep aid, anxiety medicine, or sedating antihistamine. The 2023 American Geriatric Society Beers criteria warns about the concurrent use of 3 or more central nervous system active medication classes because the combination raises fall and fracture risk. That is the central lesson of this video. The problem may not be one dramatic pill. It may be the total sedating load created by several reasonable prescriptions from different clinicians. Consider a realistic example. One doctor prescribes gabapentin for nerve pain, another continues lorazepam for anxiety. An urgent care clinician prescribes a muscle relaxant for a painful back spasm. At home, the patient buys a nighttime allergy product. Each decision may have had a reason, but unless someone sees the complete list, no one may recognize the cumulative effect on alertness, vision, blood pressure, and balance. This is why a medication review must include prescriptions, over-the-counter drugs, vitamins, herbal products, CBD or cannabis products where used, and alcohol. It should also include medicines taken only as needed. That bottle used twice a month still matters if those 2 nights are when a fall is most likely. Warning signs worth reporting include a new fall or near fall, needing the wall or furniture for support, new daytime sleepiness, confusion, blurred vision, unsteady walking, fainting or dizziness after standing. Also, report a change that began after a new prescription, a dose increase, a hospital visit, or an illness. Do not dismiss a near fall just because you caught yourself. A near fall is information, and information gives you a chance to act before an injury. Here are the 5 questions to take to your doctor or pharmacist. First, which of my prescription over-the-counter and as-needed medicines can cause drowsiness, dizziness, blurred vision, confusion, low blood pressure, or slower reactions? Second, am I taking 2 or more medicines with the same effect, especially medicines that act on the brain or lower blood pressure? Third, are all of these medicines still necessary? And am I on the lowest effective dose for my current age, kidney function, liver function, and health conditions? Fourth, could the dose or timing be adjusted to reduce nighttime risk without reducing the treatment benefit? Fifth, if a medicine should be reduced or changed, what is the exact supervised plan? What withdrawal symptoms should I watch for? And when should we follow up? Prepare before the appointment. Put every bottle in a bag or make one accurate list with the drug name, dose, time taken, and reason. Include products marked PM, sleep, allergy, cold, pain, or natural. Write down every fall, near fall, and dizzy spell from the past 6 months. If possible, bring a family member who has noticed changes. Then ask for one coordinated plan. You are not asking the doctor to remove every medicine. You are asking which benefits remain essential, which risks can be lowered, and how changes will be monitored. Sometimes the answer is a lower dose. Sometimes it is a different time of day, a safer alternative, treatment of the underlying sleep or pain problem, physical therapy, hydration guidance, or fewer overlapping medicines. While that review is being arranged, improve the environment around the times you are most vulnerable. Sit on the edge of the bed before standing. Rise slowly and pause before walking. Use a night light that clearly illuminates the path to the bathroom. Keep glasses and a stable mobility aid within reach. Wear secure footwear, remove loose rugs and cords, and avoid walking in socks on a smooth floor. These steps do not replace a medical review, but they create a wider margin of safety. If you fall and hit your head, especially if you take a blood thinner, contact a healthcare professional promptly and follow their emergency instructions. Call 911 for loss of consciousness, new weakness or numbness, trouble speaking, severe confusion, chest pain, difficult breathing, or an inability to get up because of severe pain. A fall can be a medical event, not merely an embarrassing accident. The purpose of this video is not to make you afraid of your prescriptions. The greater danger is staying silent when your body is giving you new information. A medicine that was appropriate 5 years ago may still be exactly right today, or its dose, timing, and combination may deserve another look. That decision belongs in a conversation with your healthcare team. Remember the warning signs: a new fall, a near fall, dizziness after standing, unusual sleepiness, blurred vision, confusion, or a change in walking after a medication was started or increased. Write it down. Bring the complete list. Ask the 5 questions. A 10-minute medication conversation could protect far more than your balance. It could protect your confidence, mobility, and independence. If this information helped you, share this video with one parent, spouse, friend, or caregiver who manages several medications. Subscribe to Doctor's Honest Take for clear senior health guidance without panic or false promises. And watch the next video on screen if you take lisinopril, losartan, or amlodipine after 60. It explains what to monitor and what to discuss before your next appointment. Stay informed, stay steady, and never change a prescription without speaking with your doctor or pharmacist.